Let's move on to the coagulation factor abnormalities, which is going to cause bleeding. So the first one will be hemophilia A. So it's a very favorite question for every one of us, we know. So here the factor 8 is going to be deficiency. So hemophilia, it is also called as anti-hemophilic factor, right? Hemophilia factor 8 is also called as anti-hemophilic factor. So in hemophilia A, it is going to be factor 8 deficiency. So factor 8 was involved in the intrinsic pathway. And then it is a X-linked recessive disorder. So hemophilia is an X-linked recessive disorder. So in any X-linked recessive disorder, females are going to be carriers while males are going to be affected. So only males will be affected, and this they'll be having a family history because it is an X-linked recessive, right? So males will be affected. You will have a family history. Clinical features. So now let us see about the presentation of a clotting factor deficiency. So bleeding functions was purpura. It was purpura, ecchymosis, and then hematoma. In platelet disorders, be it number or function, you are going to have petechiae, purpurae, along with mucosal bleeds and intracranial hemorrhage. While in this clotting factor deficiencies, you are going to have, so just like that with a trivial injury also, the patients will bleed. And other than that, the most important thing is there is going to be a delayed bleeding. Okay. So immediate bleeding is not going to be there. It is going to be a delayed bleeding. Suppose 12 to 24 hours after. So after the injury, 12 to 24 hours after, there is going to be unstopping bleeding. Okay. So continuous bleeding, excessive bleeding is going to be there. So massive hemorrhage after a trivial trauma is there. And the most important thing about clotting factor deficiency presentation is there is going to be bleeding inside the muscles and the joints. So intramuscular and intra-articular bleed is the characteristic finding of any clotting factor deficiency. So if they given the history of intra-articular or intramuscular bleed, they are meaning some clotting factor deficiency. Okay. So these two are the most important ones. So when it bleeds into the joint, it is obviously with repeated joint bleeding and resolution, it is going to cause lots of joint deformity. So they can have joint deformity as well. And finally, they can also have lots of intracranial hemorrhage. So intracranial hemorrhage is much more common in here as compared to that of a platelet deficiency. Okay. So in both of this, you are going to have intracranial hemorrhage. So in platelet, it was an immediate kind of bleeding. In clotting factor, it is a delayed kind of a bleeding. In platelet, it is mucosal bleeding, while it is an intramuscular and intra-articular bleed in a clotting factor deficiency. So this is the mantra. So what are the findings you see in a hemophilia? So here the platelet count should be normal. So nothing wrong with the platelets here. So BT will also be normal. Even the platelet functions are normal. So BT will also be normal. So the PT, how will it be? PT is going to affect the extrinsic pathway. But here we are going to have the intrinsic pathway which is defective. So PT will also be normal. But APTT is going to be elevated because factor 8 is involved in the intrinsic pathway. Then the main thing which we'll have to do is we'll have to do a factor 8 assay. So factor 8 levels you'll have to measure in the blood, and with that you can confirm. So factor 8 assays are going to be decreased. So based on the levels of factor 8, you are going to classify the hemophilia into a severity. So mild disease, moderate disease, and severe disease. Mild disease is one in which there is going to be at least 60 to 50% of the normal levels of this factor 8. While in moderate severity, you are going to have 1 to 5% of the normal levels of von Willebrand factor. And in severe disease, you are going to have less than 1% of the normal. So less than 1% of the normal, imagine. Okay. Then, so treatment again, desmopressin we can give to release the von Willebrand factor. So when von Willebrand factor is going to be there, it is going to bind this factor 8 and keep it protected rather than singly lying just like that. It is going to be damaged, right? So von Willebrand factor, if it is going to be there, it is going to protect the factor 8. So desmopressin you can give for mild diseases. Then you can also give recombinant factor 8. So where recombinant factor 8 is used in severe conditions. So this recombinant factor 8 is given the name Humate. Humate is the drug. Okay. And then you can use cryoprecipitate because it is containing factor 8, factor von Willebrand factor, and then fibrinogen. So cryoprecipitate as such you can give. Okay. Then there is something called as factor inhibitors. So as the name suggests, there is going to be inhibitors against the clotting factors. So these inhibitors can either be formed by themselves, like during an autoimmune condition. So some autoimmune antibodies can be formed against factor 8, or during pregnancy this autoantibodies can be formed, or there can be post recombinant factor 8 after giving this humate therapy. These patients can develop inhibitors to factor 8. So this factor 8 inhibitors, if they are present, so whatever factor 8 replenishing you are giving to the stores, so you are giving cryoprecipitate or you are giving a recombinant factor 8, still it is going to be depleted, because this factor 8 inhibitors will then break down those factor 8 as well. So it is not going to be of any use. So how do you identify the presence of this factor 8 factor inhibitors? So whenever you see an isolated APTT elevation, so in this condition, if you see PT is normal, BT is normal, PT is normal, only the APTT was elevated, right? So whenever there is an isolated APTT increase, you'll have to do something called as mixing studies. So mixing studies is nothing but you are taking the platelet rich plasma of the patient, along with that you are taking a normal plasma also, so from other normal candidate. So we are going to pool these two in a ratio of 1:2. So test plasma is there, the normal plasma is there, we are making a mix of it, so 1:1 ratio is there. So now after this, if you are going to repeat the APTT on that sample, then if it normalizes, if the APTT has normalized, it means there was actually a factor deficiency, okay? Because now that we had given the control also, this control must have had the factor 8. So the factor 8 from the control must have normalized the ratio here, and that is why the APTT is normalizing with mixing studies. So whenever it is normalizing after mixing studies, it means that there was a clotting factor deficiency only. And initially, if it normalizes and after incubation for 2 hours, if it prolongs, then it means there is a factor inhibitor. So initially we are having this controls factor, right? So this factor which has come from the control is going to be more than that of the inhibitor. So initially they'll block all the inhibitors now. So there is going to be excess. So the APTT will come to normal. But after some time, so after incubation, this factor 8 inhibitors will start coming and attacking the control as well. So then after some time the APTT will prolong. So this is the characteristic thing. Initially it will normalize and later on it will prolong in factor inhibitors. But if it keeps on prolonging, it didn't diminish at all. It just kept on prolonging together. Initially also it didn't diminish. After incubation also it didn't diminish. It means that there is an lupus anticoagulant. Okay. So these 3 things can be asked. So after mixing studies, if it normalizes, it is a clotting factor deficiency. If it initially normalizes and later on prolongs, it is a factor inhibitor. While if it is just prolonged even after initially also and after prolongation also, it is there is a lupus anticoagulant, like in SLE, right? Lupus anticoagulant in APLA, like antiphospholipid antibody syndrome. So in these conditions, you are going to have this lupus anticoagulant. It is a autoimmune autoantibody itself. So this is going to act against this factor continuously, right? So now they had seen that. Next we'll see about hemophilia B. So like hemophilia A, this is also an X-linked recessive disease. So affecting males, and females are going to be carriers. And this here, the factor which is deficient is factor 9. So factor 8 deficiency is hemophilia A, factor 9 deficiency is hemophilia B, and this factor 9 is called as Christmas factor. So this disease has been given the name of Christmas disease. So Christmas disease is hemophilia B. Okay, so this factor 9 is also involved in the intrinsic pathway only, right? So intrinsic pathway is going to be defective. So what will happen to the PT? PT will be normal while APTT is going to be elevated. So everything will be the same. Presentation of the patient, X-linked recessive, the clinical features, everything is going to be same as that of the hemophilia A only. But if you only difference is when you measure the findings are going to be same, right? Only difference is when you measure for the factor 9 assay. So factor 8 assay is going to be normal here and factor 9 assay is going to be decreased. And treatment as such, if you'll have to give a recombinant factor 9 only here, and then you'll have to give FFP and not cryoprecipitate, because cryoprecipitate doesn't contain factor 9. So you'll have to give a fresh frozen plasma which contains all the coagulation factors. Okay. So something called as hemophilia C is there. So what is hemophilia C? Hemophilia C is factor 11 deficiency. Okay, and this is a kind of mild deficiency. Factor 11 deficiency is a mild deficiency. Usually it doesn't present much. And parahemophilia is when factor 5 is deficient. And remember, factor 5 and factor 8 were the labile factors. So we also can have a factor 13 deficiency. So suppose there is a bleeding defect is there, some bleeding manifestation is there, but if you do every screening test is going to be normal. So platelet count will be normal, BT is going to be normal, PT is going to be normal, even APTT is going to be normal, because factor 13 was not involved in any of the intrinsic or extrinsic pathway, right? Factor 13 was the clot factor stabilizing factor. So it was involved in the cross-linking of the fibrin. So without cross-linking, the fibrin which is formed is not going to stay. It is going to be lost and the patient will bleed. So all of these factors, all of these screening tests are going to be normal, but still the patient is going to have bleeding. So in that case, what will you suspect? You will have to suspect a factor 13 deficiency. And how do you confirm it? We have a clot lysis test. So we'll have a clot stabilizing or a clot lysis test. So with that we can find the factor 13 deficiency. So my factor 11 is, so what was hemophilia A, B and C? A was factor 8 deficiency, B was factor 9 deficiency, then C was factor 11 deficiency.